structure? You all know? You know, when we see beans, we say that it's a kidney shape. When we see kidney, we say it's a
bean shape.
So it's a bean-shaped organ, and this is the outer surface, and you know, this is glistening. I am sure you must have seen a live kidney in your hand while we were sacrificing in Eid al-Adha, so we get also kidneys. So this time when you have your Eid al-Adha, hold the kidney in your hand so that you can easily, and then you cut it from the half, open it and visualize it, right? So when the kidney is basically brown colored, glistening, sharply glistening. And if it is glistening brown color, not granular, then means the kidney is okay. There is no problem in the kidney. But if you see wrinkles in the outer surface, or it is not shining, means something is wrong in that kidney. I don't know, you people are fond of eating kidneys or not. Nobody. I have seen very less amount of girls even touching kidneys. Okay, so we have in kidney both medulla and cortex, as we have in other organs. So the outer portion of the kidney is called cortex. The inner one, which is called medulla. And we have multiple pyramids. These are all pyramids, right? And then it opens in a papilla, this one. And these are the renal colices. Renal colices, they converge to form renal pelvis. And this pelvis opens into ureter. So this is how the whole kidney is. We have cortex, we have medulla, then we have pyramids. Now these pyramids has tubules which collects the urine from the glomeruli, and then they converge to form these colices, and those multiple colices, they converge into a pelvis, and then this pelvis narrowed down in a funnel shape and joined to the ureter, and this ureter goes down and joins the bladder. This is how it is there. So we have renal artery and the renal vein, and if you see it clearly, renal artery start from here. First it becomes a segmental artery here, then from segmental artery into the interlobar artery here, and from this interlobar artery becomes the arcuate artery. Now this arcuate artery is almost traveling alongside of this pyramid, and this arcuate artery gives twigs. These are the twigs, and they form interlobular artery. Now this interlobular artery is giving twigs to the each and every glomerulus. If you are talking about one glomerulus, it's glomerulus. But if you are talking more than one, it is glomeruli. In Arabic, probably you call it glomeruli, probably. You cannot pronounce G, girl. Or you can, glomeruli. Most of the Egyptian people, instead of calling G, they call it girl. Gamal Abdul Nasir. And I was surprised to see I was traveling from Makkah to Medina, and the bus driver was saying, Gadda, Gadda. I thought it Gadda. Actually, he was saying Jadda. So, glomeruli, if it is more, or it is more one, it is glomerulus. Now, same time, we have vessels or veins. So these are the arcuate vein, which is on the pyramid, and then this is interlobar vein. Then we have this segmental vein, and then it goes to the renal vein. So other things we have this is renal column. Renal column is in between the two pyramids. It is just a junction of the cells to hold the pyramid at one side. I think it's clear now. I'll not go in detail because you know it. We'll go to the histology then. So if you see the histology, this is a low power view, and in which you can see one glomerulus, the other one, third one, this is probably the fourth one, this is the fifth one. So I can see 5 glomeruli in this lobar. These are all tubules, right? This is a blood vessel, this one. And in between the tubules, we have interstitium. In between the tubules, remember, if you are looking at a normal kidney, you will hardly see interstitium. Hardly. So the tubules are attached to each other so tightly that you hardly see interstitium in between. This is the high power view. Remember one thing more. As we have four different portions of the kidney. One is glomerulus. Number two is tubules. Number three is blood vessels. And number four is interstitium, right? So while we are reporting a kidney biopsy, we had to put headings all differently. First of all, we'll write glomerulus. And then we'll full define the whole glomerulus. Then number two, tubules. So what changes we are looking at the tubules. Then we add interstitium. What changes are we seeing in the interstitium? And then finally blood vessel. So we report kidney like that one. Okay. Now we have taken one glomerulus to show you high power. So this is one glomerulus. This is an artery which is going and then it forms tuft of the glomerulus. This is the space which is called Bowman space. This is Bowman capsule which is formed by parietal epithelium. Okay, and these are proximal convoluted tubules which are bigger in size, more pink in color. And the outer one is distal convoluted tubules. So they are thinner as compared to the proximal one, right? And the color is also a little lighter, so as compared to the proximal one. Clear? Okay. Then we see the electron microscopy in detail. So this is one tuft of glomerulus. So this was the artery which was going in, efferent and efferent, and they are forming a multiple small capillaries inside to form a glomerulus. Now we have taken a section from, suppose this one here, and we open it here. So this is one capillary. Inside it is endothelial cell, right? And you see fenestration, means holes in the endothelium. We need holes because we had to pass fluid from inside to outside. Now this is a basement membrane, right? This is basement membrane, and outer side it is visceral epithelium, not parietal, visceral. So visceral epithelium is holding the blood vessel from outside. Endothelium is holding from inside. Endothelium has fenestration. The epithelium, which is visceral epithelium, has podocytes. So the whole, somewhere you can see a nucleus which is not identified here, but this is basically the whole cytoplasm of one visceral epithelium. And the cytoplasm is expanded in such a way that it is holding the blood vessel like this one. So they are forming a foot processes, right? So foot processes is giving space in between so that the fluid can easily pass through. You know that kidney is really very important to take rid of the toxic materials. So all the time it is doing their work. So when the blood comes there, it goes towards the from inside to outside and then passing through the basement membrane, right? So it is the high power view. This is the basement membrane, this one, and this is the endothelial fenestration pores. This is the foot processes. Normal. Clear? Should we move now? Now, by looking at this picture, probably it will be more you can identify. So this is one portion of the glomerulus. This is not the whole glomerulus, remember. This is a portion of one tuft. So there are multiple tufts in the glomeruli. Now these vessels are held in between by mesangial cell, this one, cream. There are only two or sometimes three, right? Two or three. So the function of this mesangial cell is to hold the vessel tightly. Here we have seen in the diagram there are 4 vessels, 1, 2, 3, 4, which are being held by this mesangial cell, right? Now, this is a basement membrane which is going on around this vessel, but this is the only organ of the body in which the basement membrane of the vessel is not completely encircling the blood vessel.
It's just on the outside.
It's only on the outer side. Clear?
Yes.
It's very important point. Remember, I'm saying it again. The blood vessel of kidney has a specific feature that the basement membrane is only covering the outer portion of the blood vessel. It is not covering the inside. The inside is supported by mesangial cell. So it is covering from the outside like this, and then we have podocyte. This is blue color. This is a nucleus of the visceral epithelium, and this is all cytoplasm which is holding the whole one together, and it is holding like a 4 processes. So from inside, if you see fenestration holes. This is endothelial cell. This is one endothelium cell. This is a nucleus, and this is fenestration going on throughout. Outside, it is visceral epithelium with the podocytes, and this is a parietal cell, right? So parietal cell is actually lining the Bowman capsule, outer one. So the importance of this thing, which I have shown you tomorrow lecture, when we will be discussing the membranoproliferative or mesengocapillary, ones we used to call. This mesangium, when they proliferate, what happens? Because they increase in size. So where it go? So they form, or they get a place here in between the basement membrane and the endothelium. This is called interposition of the mesangium. You understand what I'm saying?
Yes.
So it goes in between the endothelial cell and basement membrane. So for example, this is endothelial cell, this is basement membrane, so and this is mesangial cell. So it started bifurcating this, and it started going in between, and it encircle the whole blood vessel like this, and they form a false basement membrane, false, which you see in membranoproliferative, which we will discuss tomorrow. But I will ask this thing, that do you remember my last lecture in which I showed you that mesangium is covering the inner one?
Doctor,
Now, yes.
well, you just explained this is the railway track appearance, right?
Yes, this is why it is called tram track appearance, because they bifurcate and it looks like a tram track appearance. If you do your silver stain, then you will see exactly the tram track, because in between there is interposition of the mesangial cell. Clinical manifestation. So first of all, we should know what are the different clinical manifestations. It's acute nephritic syndrome, rapidly progressive glomerulonephritis, nephrotic syndrome, acute renal failure, chronic renal failure, and then asymptomatic hematuria or proteinuria. So there are 6 different clinical manifestations. We will start with one by one. What is nephritic syndrome? So nephritic syndrome, usually you have gross visible hematuria. Gross visible means with your naked eye you can see that the urine is red. Microscopic hematuria means you will see a yellow color urine, but there is some RBC which you are not able to see. Gross hematuria means red color, right? Mild to moderate proteinuria. So the proteinuria will be in between 1.5 to 2.5, not more than that. And also you have hypertension. So 3 important things. Number 1, hematuria, mild to moderate proteinuria, and hypertension. 3. Number 2, rapidly progressive glomerulonephritis. You have, the same nephritic syndrome when it becomes, or it is not well treated, it becomes with the rapid decline of the GFR. What happened here? The parietal epithelium, they start forming crescent. Remember, crescents are always formed by parietal, not visceral. The other proliferation is done by visceral epithelium, means visceral epithelium, endothelium, and mesenchyma. For example, the post-streptococcal, all three of them proliferate, but not the parietal one. Parietal one only proliferate when it deteriorates. The functions deteriorate, high level, right? And then they started developing one. And if this thing has happened, means you had it. Even if I'm sitting in my clinic and looking at the biopsy, and if I see crescent, at once I will call Dr. Khalid Amri. Go and look for your patient. No matter it's 12 o'clock in the night. Because this is an alarming situation to see crescent, rapidly progressive. Then, nephrotic syndrome. Now, in nephrotic syndrome, you have heavy proteinuria, not mild to moderate, heavy. Means more than 3.5 milligram per day. Grams per day. And you have hypoalbuminemia. Why hypoalbuminemia? Because the albumin is being secreted or excreted through urine. So in the body, there will be low level of albumin, hypoalbuminemia. Severe edema. Why?
Decrease in
Oncotic pressure is decreased. So you have fluid in a third space. Hyperlipidemia. To compensate the oncotic pressure, body start making more and more lipid, at least to compensate something. And then finally lipid urea. Because if there is increase in the lipid level, the lipid can come in the urine. So you can have lipid urea. So 5 things here. Number 1, heavy proteinuria more than 3.5. Hypoalbuminemia, decrease in the albumin. Severe edema, pitting edema, that is called. Hyperlipidemia, means lipid is increased, and lipid urea. 5 important. The 4th thing is asymptomatic hematuria and proteinuria in some patients. You have either hematuria or mild proteinuria, or you can have both. But they are asymptomatic. The patient goes to the doctor. Doctor asks for, okay, go for CBC and urine analysis. And in urine analysis, they see 3 to 4 RBC or a little amount of traces of albumin. So you say that it's asymptomatic and nothing is going on. No symptoms are being produced. So they are asymptomatic. And I have seen in my clinical practice that many patients in my knowledge that they have asymptomatic proteinuria. Acute renal failure. Now what happens? It has oliguria and anuria. Oliguria means less amount of urine, and anuria means complete stoppage of urine. No urine flow. Or recent onset of azotemia. What is azotemia?
Increased creatinine in the blood. Yeah, it was not enough
To
cause uremia.
what do you mean by uremia? Now the second question is.
What was your question?
The question is, you said that it is so low that it does not cause uremia. Now the second question is, what is uremia? High. Now, listen carefully. In azotemia, there is high BUN level, blood urea nitrogen, or probably serum creatinine will also be raised, but without sign and symptoms, right? In uremia, blood urea nitrogen is high with sign and symptoms of urine. That's why we call it uremia. If there is no sign and symptom, we will call it azotemia. So this is the difference between these two. Okay? So we have azotemia. It can result from glomerular interstitial or vascular injury or acute tubular necrosis or injury. Finally, we have chronic renal failure characterized by prolonged symptoms of uremia, sign and symptoms. So now we have both sign and symptoms. And there is an end result of chronic renal parenchymal disease. So every renal parenchymal disease whatsoever, which we are now discussing, ultimately go to chronic renal failure, right? Now, pathological manifestation, you can have cellular proliferation, like we are going to discuss now, acute diffuse proliferative glomerulonephritis, or post-streptococcal one, in which we have mesangial proliferation, endothelial proliferation, and visceral epithelial proliferation, not parietal one. Number one. Then leukocytic infiltration, you can have neutrophil, you can have monocytes, sometimes you can also have lymphocytes. Then cretin formation are rapidly progressive, in which you have parietal epithelial proliferation, which is not seen in the first one, right? So now whenever we talk about rapidly progressive or crescent formation, the first thing should come into your mind that the parietal cell is being proliferated. Then we have basement membrane thickening, which we will discuss tomorrow in a membranous one, and hyalinization and sclerosis. This is fibrosis of the kidney. This is the end result of that. Pathogenesis. Either we have antibody against inherited GBM, means the GBM itself become antigenic, the whole GBM, and antibody will go and attach to the GBM. Now in this type, you will be having a linear type of IMF. What is linear type? I will show you, right? Just remember, in GBM, you have a linear type of IMF, immunofluorescence microscopy. Antibody against planted antigen. Now the antigen is roaming around, they plant it over the basement membrane. The basement membrane is not antigenic. In the first one, basement membrane itself become antigenic. Now in the second one, the antigen come and lodge on the basement membrane, right? Now antibody, which is in the body, which will go and attack or attach to the planted antigen. If you do IMF here, you will see a granular type of deposit, not linear, because it is haphazardly placed. Clear? Then we have trapped antigen-antibody complexes. Antigen-antibody complexes are floating in a blood, and blood passes through the kidney and they are stuck in the basement membrane. So this is stuck in the glomerular membrane, again they are stuck as a haphazardly, not linearly. So if you do IMF here, what it will show? Again granular. So you have granular all the time, but you have linear in antiglomerular one, right? Then we have antibody against glomerular cells, like mesangial cell, like in your case, today's PBL. IgA is attacking the mesangial cell, and you did IMF and it was granular. Why? Because it is haphazardly been placed. And finally, cell-mediated immunity, that is the sensitized T cell, as you see in tuberculosis. Now, just think what I have said. In the center one, this is anti-GBM. Now, in the anti-GBM, the glomerular basement membrane itself become antigenic. So you see that the antigen is placed regularly. So when IMF will do stain, it will be linearly placed. On the right side of my hand, it will be right of you also. So you see the antigen which are circulating around and they are planted on the GBM, right? So they are haphazardly placed. So when antibody, these are antibodies, this one, black one, these are. So when the antibody come and they attach on the planted antigen, so they are haphazardly placed, right? And in the third, on the left side, these are the circulating antigen-antibody complexes. So when they come and trapped in the glomerular basement membrane, again they are trapped in a haphazard way. right? So when you again do IMF, it will be a granular type. So what is these? See these two pictures. Now this is granular type of deposit. You see granules here, and this is the linear type of deposit. You see the difference? Although because you are new, third year student, probably you will not be able to appreciate more, but we have an experience of looking again and again, so you can easily visualize. But I think it's so clear. It's clear, huh? You can see the granules on that one, and here it is all linear, no granules. Clear? Now, yes.
Can you just go back to the previous slide? So for the one in the middle, the anti-GBM, this one, this is
The whole glomerular basement membrane become antigenic.
okay.
So,
An
sorry?
example of this would be
Good posture. Yes.
Okay, so for the other one, for the C one, what is an example for this?
We will see. When we will be discussing that one, we will come to it, right? So there are different examples of that.
Yeah.
For example, immune complexes, this is post-streptococcal one.
Okay.
So, and this is, when we will be touching that one, we will discuss that one. Okay. So, now this is another picture. Now, this is the electron microscopic picture, and you see these are the podocytes for the visceral epithelium. Inside, this is the endothelial cells showing the pores, and this is the diagrammatic picture of it, podocytes and the pores, and the fluid can travel from here to here, and this is actually polyanionic one. So they have, every fluid cannot pass through. So they have to show their passport or visa to pass through this one. Normally, albumin are not allowed to pass from here. Why it passes means some damage to these podocytes or the so some problem is going on. That's why it is allowing the albumin to pass through this one, right? Mediators. So we have neutrophil and monocytes, we have macrophage T cell, NK cells, we have platelets, we have mesangial cells, we have soluble cytokine and chemokines, and also we have coagulation factor. So this basically mediators you all know. These are the chemical mediators which are being secreted and they causes a process of inflammation to start. Okay? We will starting the first one is post-streptococcal or post-infectious. When we were students like you, we were supposed to know that it is only the post-streptococcal which causes this thing. But now it is clear that it is not only post-streptococcal, but there are other organisms which can cause the same thing, right? But we will take post-streptococcal as a prototype. We will discuss the whole thing, and then at the end we will see what are the different organisms. Okay. So in this one we have a diffuse proliferation of the glomerular cell. This is also called acute diffuse proliferative glomerulonephritis. Acute diffuse proliferative. So there is a proliferation of glomerular cells with influx of leukocyte caused by immune complexes. So these immune complexes are of probably streptococcal with antibody. The patient may have hematuria, have azotemia, oliguria, and they are mostly seen in the children with the following type A streptococcal infection. Okay? I think you have gone through while we were doing CVP block.
Yeah.
Which disease?
That's rheumatic.
Rheumatic, definitely, same. Now, this is post-streptococcal, or this is the old term which we usually call. There is hypercellular glomeruli. Hypercellular, so the hypercellularity will be mesangial, endothelial, as well as visceral epithelial, right? And also some of the neutrophils. Increased endothelial and mesangial proliferation, there will be deposit of IgG, IgM, but not IgA, which was there in your PBL case, plus C3. Hepatology, they are seen in children mostly, but other people are also involved. The peak incidence is 5 to 20 years of age. Male to female ratio is 3:1, and the frequency is in the developed country is almost declining because they have good hygienic condition. Even they don't have post-streptococcal infection there. So majority of the things are clear there, but in the poor countries like Asians and Africans, still we have the same process. So developing country like Asia and Africa, and there is 95% recovery rate, 95%. So although if the patient are being involved with this one, and if he is been treated, there is a recovery chance of 95%. So it's preceded by acute infection or acute pharyngitis with type A beta hemolytic streptococci. So they are called post-streptococcal GM. The nephritogenic type is 1, 4 and 12. There are many, but this one is important. 1, 4 and 12. Complement level is also low because it is also involved in in deposition in the glomeruli. There is a granular immune deposit in the glomerulus, granular, and also there is subepithelial deposits of immune complex appear as a hump on the subepithelial surface. Now this thing you only see in electron microscopy. You cannot see this thing in a light microscopy. The microscope which we have, or microscope which you used to see in your micro lab, they are called light microscope, right? An electron microscope is totally different. It needs the whole room. It's a huge thing, right? We have there in our KFSH. So clinical features: rising anti-streptococcal antibody titer that are identified in 80% of the patient. So it is called ASO titer, which you see in streptococcal pharyngitis after 10 to 14 days. And those who had skin disease, which is pyoderma, anti-DNase B is positive in those ones. Clinical features: this patient has malaise, fever, nausea, oliguria and hematuria. And the hematuria will be smoky or cola color. Remember, cola color urine, if you see, the first thing come in your mind will be post-streptococcal. 1 to 2 weeks after recovery from the sore throat. So in this scenario, mostly the patient will be a child. In your case, the patient will be, was how much year? He was 27 years old, right? He's a PhD student.
Yes.
Young man. So Iga Nephropathy usually involve young adult. This usually involve children. So by looking at the epidemiology, many of the things can be cleared easily. Okay, so red cell cast in the urine, mild proteinuria, less than 1 gram, periorbital edema, and also moderate hypertension. So these are the clinical features. In adult, the onset is more likely to be atypical. Means probably he might not be having malaise or fever or hematuria or cola color, but he must be having hypertension, edema, and increased blood urine nitrogen. So in adult, it is not a typical picture which you see in the children. Important laboratory finding is ESO titer and low level of C3. More than 90%, as we have discussed, the children recovers with their conservative treatment. Small minority of the children, less than 1%. I'm going for the attendance now. Okay. And call your friends outside to come in because I'm going to take their hand. So, become severely oliguric and develop rapidly progressive. So, these patients which are not being treated properly, now they are going to develop rapidly progressive. So, what will happen in rapidly progressive? Crescent. And crescent, how it is formed? Parietal epithelium. So, parietal epithelium is now being proliferated. Rather than from inside, now it is coming from outside. Some of the remaining patients may undergo slow progression to chronic glomerulonephritis. As I said, almost all glomerulonephritis ultimately ends up into a chronic one. Prolonged or persistent heavy proteinuria and abnormal GFR mark patient with an unfavorable prognosis. So there are some other infections like bacteria, like Staphylococcus endocarditis, pneumococcal pneumonia, or meningococcemia. They cause almost the same thing. Viral like hepatitis B, hepatitis C, mumps, HIV, varicella, or infectious mononucleosis. Or we have parasite like malaria or toxoplasma. Or in these settings, the granular immunofluorescence deposits and subepithelial hum characteristic of immune complex nephritis are present. So this is how it looks like. So if you see, these are the low power. So you can see 1, 2, 3, 4. Remember, kidney biopsy, you have to count glomeruli. In each report, you start with this. For example, I said that you have different sections, glomeruli, tubules, interstitium, and blood vessel. In glomeruli, the first thing you write is there are 5 glomeruli, there are 10 glomeruli, there are 2 glomeruli. You start your statement with showing the number of glomeruli. For example, now if I'm seeing under microscope, so I'll write that 1, 2, 3, 4, 5, and the 6th one is half. So I will see probably 5.5 glomeruli, right? I had to write 5.5 or 5 glomeruli. See, which shows proliferation of endothelium and mesenterium as well as endothelium, mesenterium, and epithelium. So all of the 3 components. Plus, you can see some of the neutrophils. So here are the neutrophils. In a high power, these are all neutrophils. You see? You see? You see here? These are all neutrophils. It is not necessary for you now to identify each and every cell, right? But you should see that you have seen multiple neutrophils here. But it is all proliferating. The whole glomerulus is involved, not a segment of it. Then it becomes a different entity. We will discuss that in tomorrow. These are 2 more pictures. The whole glomerulus is involved. And you can see neutrophils here, 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 means every segment. But the parietal epithelium is okay. You see? No proliferation in the parietal epithelium, even in this one. Parietal epithelium is not proliferating. Only inside it is proliferating, all these segments. Now this is immunofluorescence, IMF. Starry sky pattern means granular deposits of IgG and C3, right? So this is how it looks like. Granular deposit. We have a separate room for IMF. We cannot see IMF sitting in my office. So it's a dark room. Even the walls are being painted dark. There should be no window, or if there is window, it should be painted black. So when you turn off the light, you can hardly see your hands. You see? So dark. Only when you on your microscope, you will see only the microscopic light. And when you put this light, you see IMF. Otherwise, in a light, this type of room, you will not see anything. Clear? Okay. This is electron microscopy, basement membrane. These are the humps. You see? This is subepithelial humps. So this is endothelium, this is epithelium. So this is subepithelium. Now what they say is, they start coming from inside. So this is a blood vessel. So they were coming from this side. They crosses the endothelial cell. Initially, they are in between the endothelium and the basement membrane. Then they cross this basement membrane and come on the top of it. So at the time when the patient comes to us, we see subepithelial humps, because they have crossed the whole thing. At the time, for example, it is 14th day or 15th day, by that time, the antigen antibody complexes has traveled from inside to outside. But probably, 1 or 2 humps you can see subepithelial also. But majority you will see outside. Okay, clear? Yes.
What is the
Here in this one, for example, this is endothelial, right? Inside, this is blood vessel, and this is epithelium, visceral epithelium. Here, this is visceral epithelium. You can even see podocytes. This is endothelium, and this is hum. Clear? So this is subepithelial hum. Why we call all the time subepithelium? But whenever we take biopsy, by that time, most of the immune complexes are present in the subepithelial area. Now prognosis, as you know, 95% they recover completely. Recovery rate is lower in the crescent one. Yes, when crescent or rapidly progressive occurs, then the recovery will be a little lower. In adult, 25% or more have long-term sequelae, such as persistent renal dysfunction and proteinuria, right? So they take longer time, not like children that they come up like this and they go recover like this, but they take a little longer time. Now coming to crescentic glomerulonephritis, so let's go your attendance first. Okay. Ready? If you are not able to do from your seat, you can come here. The lecture is not over. Lecture माफी खलास. Okay, so everybody done? Yes. So I'm giving 20 seconds more. Yes. Done? Okay. Now coming to the crescentic one, and you all know that the same post-streptococcal glomerulonephritis, if it is not recovered properly, it will change into a rapidly progressive. And in rapidly progressive, what happens? Crescents are being formed. So this is a crescent which you see here has been formed. This one, crescent. So we know that this is not a specific type because it's not specific for streptococcal. It can be any of the organisms. So there are three types. One is anti-glomerular basement membrane antibody associated, or immune complex associated, or anti-neutrophilic antibody, which is also known as anti-neutrophilic antibody. Have you heard this before? ANCA, And how many NCA we have seen? Number one, number two, yeah, and Church Strauss, right? So we have P and C NCA, right? Two important ones. So in these patients we have rapid loss of renal function, so deterioration, oligouria to anuria. Then we have hematuria and proteinuria, which is increasing in number, and crescent formation in the glomeruli. So how the glomeruli form crescent? It is not formed at once. So it starts with one corner, right? Still the whole glomeruli appears normal, right? Then again, it is almost encircling the glomeruli. It is obliterating the Bowman space. Then you can see that almost it has encircled the whole glomeruli. And in the last stage, it is almost engulf the glomerulus, and after this you will see only fibrosis. This is end stage actually. Up till stage 3, 1, 2, 3, they are manageable. If you treat the patient, probably this crescent will go away and patient will become alright. So, electron microscopy, we can see that there is disruption of the capillary wall. So this is a capillary, you can see there is damage in the capillary wall, like this one. Rupture of the capillary wall. This is why you have extensive amount of proteinuria as well as hematuria, because now it is basement membrane is damaged, it can easily pass. 3 types, as we know: immune complex mediated, antiglomerular basement membrane mediated, or post-immune, which is NCA1. So we can determine all of these 3 by doing IMF and the electron microscopy. So if you have a granular deposit, which will be, is it GBM, or NCA, or immune complex? If it is granular deposit, immune complex. If you have granular deposit, immune complex. If it is linear, GBM, yes, very good. And if it is minimal one, ANCA. Good. So you should know. So this is how, if it is immune complexes, you see granular deposits of these immune complexes in the glomeruli, right? And what are the different diseases? It is SLE, acute post-streptococcal, Iga Nephropathy, or HSP, membranoproliferative glomerulonephritis, fibrillary glomerulonephritis, or many others. So these are what they can cause this one. This is anti-glomerular basement membrane. So this is, a linear deposit. So you see how much shiny and linear deposits is this. So you can hardly see any granule on it. So linear. Is you alright? Are you alright? Okay, so there are 2 types. One is confined to the kidney, antiglomerular basement membrane of the kidney, or the other one is good posture syndrome. So what is good posture syndrome? It is not only affecting the kidney, but it also affects the lungs. So the lung alveoli, the basement membrane, is also become antigenic. So antibody also hit the alveoli. And then these patients have hemoptysis, cough or blood in their sputum. Then we have post-immune, which is NCA associated. You hardly see only this one shining. Otherwise, you will not see anything. You can compare this one with this one. Do you have any positivity? Hardly. No. Or no? Or this one. So it is associated with 3, as we said, microscopic polyangiitis, which is PNCA, vaginal glomerulopathy, which is CNCA, or Church-Strauss. Now I have mentioned this thing because we have discussed this thing in our CVP1. But in kidney, only upper two is involved, not the third one. Please kindly take this thing in your mind. The Church is just for reminding you that we have done this thing. But the first two, microscopic polyangiitis and vaginous, they are the basic two ones. So clinically, what this patient has, they have heavy hematuria, red cell cast in the urine, moderate proteinuria, occasionally reaching the nephrotic range, variable amount of hypertension and edema. In good posture syndrome, this patient has recurrent hemoptysis. Hemoptysis means
Coughing up.
coughing the blood, and life-threatening pulmonary hemorrhage because of that. The whole alveoli become antigenic and antibodies have struck them. And then finally, how to confirm? We do serum anti-GBM antibodies or serum nuclear antibody or ENCA are helpful in diagnosis of the specific type, right? Now for GBM, for example, good posture syndrome, you normally do plasmapheresis. What is plasmapheresis? Yes, you put the blood from one hand and take blood out from the other one. And you not only one pint of blood, you need many pints of blood to remove the whole blood and put a new blood. Why? We want you to take out the antibodies present in the blood. So this, by doing this, plus you also give steroid and cytotoxic agents to kill whatever the things are left behind. Some patients may eventually require chronic dialysis and transplant. So, for example, if the kidney are deteriorated in such a way, if you remember the recent one, the last slide, in which the whole of the glomeruli is almost finished. So for that one, you need to have either continuous renal dialysis after every second or third day, or if you are lucky enough to get a kidney from your relative. Because in kidney is different from liver. In liver transplant, you just do your blood group. That's all. Nothing more. For kidney, you have to do your typing to match. If you give a mismatched kidney to a patient, then you had it. Within few days, your kidney is gone. Okay? So this was all about your today's lecture. Any questions? Yes.
Doctor, can you repeat what you said about the PMSENCA? So you said microscopic polyangiitis and Wagner are the only ones involved in what exactly?
I said that I have mentioned three,
Yeah.
but the first two are involved in kidney. Only
And the
two.
kidney
Only.
Perfect.
Not the Church. This is just to remind you that we have done this three in the.
Yeah, perfect. Thank you, doctor.
Thank you very much. So tomorrow, inshallah, we'll start with the nephrotic syndrome.